In healthcare, there is often too much information and not enough time. Here at the Mel Initiative, we avoid TMI by breaking things down into language you can understand. We create a safe space for you to ask your questions and share a nursing perspective without taking up too much of your time. Today, we'll be speaking with our special guest. Kirby Williams is a psychiatric mental health nurse practitioner from Richmond, Virginia. We love to represent our whole global community, but we have a special interest for bringing attention and awareness to providers and resources in the DC, Maryland, and Virginia area so we can be known for more than politics. Although a very important component of our society, there's a whole lot more here that we offer too. If you're new here, welcome to the Mel Initiative. I'm Dr. Kimberly Madison. I'm a doctoral prepared nurse practitioner, one of your co-hosts here at the Mel Initiative, along with Alicia and Geraldine, who send their love in their absence. We're a health literacy podcast. When we say health literacy, we're talking about your ability to obtain information, to understand that information, and then to use it, to manage your health and advocate for others. It's our hope that by watching on YouTube, LinkedIn, Facebook, Instagram, shout out to Angie, or by listening on any of your favorite podcast apps, that you'll feel empowered to ask questions, educated on how you can manage your health, and confident to navigate the healthcare systems. We have two missions here. The first one is to promote health literacy amongst the public. Our second is to elevate the voice of nurses, bring awareness to all the career options in the healthcare industry, and inform our peers on how they can leverage their expertise. If you haven't already, this is your chance to subscribe so you can be notified when we release a new episode. Give the videos a thumbs up, leave a comment, share it. It helps the algorithm know that this information is important so that when people like you look for information like this, we'll show up higher in the search results. Remember, this show is for educational purposes only. The opinions expressed here are opinions alone. They're not a representation of any of our affiliations. If you're experiencing a medical emergency, you should seek medical attention and medical guidance from your healthcare provider. If you're having a physical emergency, you can call 911. If you're having a mental health emergency, you can call 988 or text 741 741. Today, I have the honor of introducing a trailblazer in psychiatric mental health, a mentor, an educator, an entrepreneur whose work is shaping the future of psychiatric mental health nurse practitioners. Since earning her psychiatric training from the prestigious University of Virginia, Kirby Williams has been making waves in the mental health field for over a decade. Starting her journey in mental health practice in 2012, she quickly expanded her reach, stepping into academia in 2013, where she educated and inspired both undergraduate and graduate nursing students for nearly a decade. In 2019, she saw a critical need and founded the Black Psychiatric Mental Health Nurse Practitioner Collective of Virginia, a community dedicated to empowering Black psychiatric nurse practitioners and addressing their unique challenges. But Kirby didn't stop there. She's a visionary behind Beacon Behavioral Health and Consulting, her private practice where she provides psychiatric services to adults in Virginia. Her passion for mentorship and education also led her to establish the PMHNP Source LLC, an innovative professional development company offering digital products and community support to guide new psychiatric mental health nurse practitioners navigating their careers. From groundbreaking initiatives to creating platforms for professional growth, Kirby is a force to be reckoned with in mental health advocacy and education. Please join me in welcoming the inspiring and unstoppable Kirby Williams.
Oh, thank you so much. Inspiring, unstoppable. I always want to be introduced like that. That is lovely.
Yeah, and shout out to Shannon Sharp, who showed us the value of giving people their flowers while they can still smell them.
Yes, I love that. Yes, yes, yes. Thank you. So happy to be here.
Oh, it's our pleasure. Before we jump into our topic, which is a really important one, especially for our community, we just want to get to know you a little bit better. So we have 5 questions that we're going to do in 5 minutes. Shout out to
Okay.
Nancy Twine, the host of Maker's Mindset, for this idea. So the first question, and don't overthink this, what's the next big idea you want to be a part of?
The next big idea. I think it's write my own book.
Oh, okay. Don't. Now you're going to take me on a whole different path. Okay, do we have a working title?
No, not a working title. Just some kind of thoughts based on kind of my own journey and what I've learned throughout my journey. Hmm.
Okay, we'll look forward to that.
Yeah.
Okay, what would you do if you could do anything for free?
If I could do anything for free, I would Travel the world. I would travel the world. That's what I
And
would
the first
do.
stop?
First stop would be Tanzania. I haven't
Oh,
been there yet, and I've always loved the pictures. And it looks like a very beautiful space, and so that's where I would like to go.
if you're watching or listening, leave her some suggestions in the comments,
Yes, please.
especially places to eat and how to
Mhm.
save a few coins.
Yes, love it all.
If you had to start over, what would you do differently?
If I had to start over, I think, and you may have had this, this may have happened to you as well as a nurse, but I think I would not have listened to the information that came out of nursing school about starting in med surge. Not that my experience there, it wasn't a bad experience by no means, but I had some interests in other areas that I felt like weird to pursue because that was kind of the word. The word was like, yeah, go here first, got to go here first. So I didn't even like lean into some of the other interests I had at that time. So I was just focused on, okay, that's what they said I got to do. So I got to do that.
We're definitely going to dedicate an episode to that whole conversation on MedSurg. So where would you start then?
Right. Great question. I think I would have started. I really think that I would have started more in like a specialty, almost like in a specialty area of like not necessarily mental health specifically, but something that was maybe more aligned with mental health. Because I remember an experience of working with a nurse who was running groups as a part of a hospital service under psychiatry, and I was like, man, that seems it seems really interesting. That seems like a really like great opportunity to do that. But then in the back of my head, I always hear like, oh, you're gonna lose your skills, lose your skills, lose your skills. And so I was like, well, let me just, I don't want to lose my skills. That's the only thing, you can think of sometimes. I don't want to lose my skills. That's what they say is gonna happen, kind of a thing. But I think something like that. I enjoyed that experience, seeing her do that. And she was just a very compassionate person. And I was like, man, this really seems cool. Are there more opportunities like this?
Hmm. And how do you want to be remembered?
Whew. That's a great one. I want to be remembered um, that I did good, that I provided a positive influence and a positive influence to others, whether that's family or even strangers that I don't know.
And who would you like to give their flowers to?
Oh, wow. I would love, wow, I would love to give my flowers to a really beautiful and awesome friend. Her name is Allison Williams. I met her through a business mentorship program when I was just kind of learning about entrepreneurship. I did this program in like 2023, 2022, and she's just been very supportive, even though she's not even in this space of healthcare at all. She's like, oh, yeah, that sounds great. That sounds good. Yes, I'm supporting you. I'm behind you 100%, always rooting for me, even if she's like, I don't really know what a PMHMP is, but sure, I'm gonna root for you. And so that's so incredible to have someone who will root for you in your corner when they don't even know like your specialty at all. It's really awesome. She's awesome.
Well, shout out to her. You did a beautiful job giving her recognition.
Yeah.
You brought up something I think is really great, and it's going to be an idea that we'll address in the future. This whole idea of specialty, right, and being afraid of losing those skills, because
Mhm.
we all hear that. And when I entered specialty, and then they needed help doing like school physicals, and I thought, oh my God, I haven't used my stethoscope, and
No.
I don't know if I can do that. And then
Yeah.
I immediately understood why people will keep that little PRN job to hold on to those skills. And I said,
Mhm.
now I get it.
Mhm.
You
Mhm.
know?
Yeah.
Um, but it's also that whole thing. If you know you want to specialize, does it even matter if you have those other skills?
Mhm. Mhm.
And so really good question.
Yeah. Or can they be learned or can they be relearned again? That's kind of
Mm,
how I think about it. If you went the other route, whatever, specialty route and
um,
lost something, could you relearn it? Is it possible to learn it again? Is it possible, that it'll just come back or something like that? It's possible.
yeah, and I know there's some our entrepreneur friends out here who have those kind of courses to help you
Mhm.
kind of get back in the game.
Yeah. Awesome. Awesome.
So we know we have a really heavy topic to talk about. We know our whole audience is here for that topic in the
Yes.
title. So let's get into it. Let's
Okay.
talk about what is bipolar.
Yeah, so bipolar disorder is a mental health condition where a person experiences sustained mood changes. Sometimes people will say sustained mood swings. And these sustained mood swings can be either depressive or a person feeling very low, or they can be kind of an elevated mood state where a person feels, I would say, unusually happy. So happy, but unusually so, or irritable, sorry, but unusually so. And again, I use the word sustain, and I try to say that a couple of times for a reason, because I want people to know that it does need to be for several days at a time. This is happening several weeks at a time. And in some circumstances, when it is untreated or not treated maybe appropriately, it could even last for several months. But it's not just someone who is maybe, people might use the term moody. It's not just a person who is moody, like when something happens, they feel mad for a short period of time, like 20 minutes or an hour or something like that. It does have to be something that is more sustained. And there are actually two types of bipolar disorder. There is bipolar 1, where the person will have some depressive episodes, but they'll also have what's called not hypo. They also have mania, which is a very elevated mood state. And that elevated mood state has to at least last a week or more to be called mania. And then bipolar 2 is where someone has, again, those depressive states or depressive episodes, but then they have periods of hypomania where they have those elevated mood states of maybe high energy, overly happy or unusually happy, those types of things. And that lasts for a couple of days. So around 3 to 4 days or so.
And so how is that diagnosis made?
Yeah, so the diagnosis is typically made through what we would call a psychiatric evaluation or a psychiatric interview, where a person would come in to speak to a psychiatric provider. And this could be someone like myself, who's a psychiatric mental health nurse practitioner. This could be with a psychiatrist, or this could be actually with a PA. There's some PAs who specialize in psychiatry. So it could be with a physician associate. It could be with that person as well. And that person would take a lot of what we call history from the individual, and we would learn about what are the experiences that they're having, and we would learn about if they're having these actual kind of episodes. Sometimes family might be involved in this interview as well, and they can provide some information. Sometimes what we'll do is when we're talking to a person that we're meeting for the first time, we might even use some what's called screening tools. There are a couple of screening tools that are used where we would have the person kind of check off, are these kind of experiences ever happened? But these are just screening tools, because if they've happened, then we need to do a deeper dive in the interview to find out how often are they happening, how long are they, occurring, what's the frequency, are they caused by anything else, is something triggering these or something like that.
Wonderful. So let's get into, you mentioned quite a few vocabulary words so far for our audience. So let's break it down, because people have heard these words over and over.
Mhm.
And even bipolar, people use it kind of, casually.
Right. Yes.
And so let's break it down for them. So how would you describe the symptoms of a depressive episode?
Yeah. So depressive episode would be a person who might look very sad, feel very sad, have sadness, maybe even express it verbally, or they may not, but you may notice that they are not expressive in their conversation, or a person who typically laughs at, jokes that you make is not laughing anymore. So something like that. The sadness doesn't have to just be expressed verbally. It could be a person who is sleeping a lot, has low energy. They're not interested in activities that they used to enjoy. So let's say maybe there's someone who, for as long as you've known them, they've enjoyed video games and basketball and going to see movies. But now you've noticed that, you will invite them to do those types of things, and they're like, not interested. They're saying no to it a lot, or maybe next time. And that's typically not their kind of general affect towards those things. Or a person might also, you might notice that they start to, not want to eat or eat too much. It's dependent, because everybody's different with their depression. Some people eat a lot more than their usual, or some people actually decrease in their appetite and not hungry at all. And they might start losing weight when they're in more of those depressive states.
And so we have bipolar that has the depression component, and then you just have people who are just depressed, right? So how do you make that distinguish? How do you distinguish?
Yeah. Yeah. So the difference in bipolar disorder versus depression, because depression can be a part of bipolar disorder, the difference is the person also has those elevated mood state periods, that hypomania or mania, where they experience being, again, overly happy. They are experiencing like a lot of impulsive decisions. They have like very, very high energy. So they might be starting several businesses or things such as that, where that's not, again, where that's not their normative. There's some people that is their normative, but that's not, outside of their normal behaviors. And then they might also like have what we call a decreased need for sleep. So the person is not sleeping much, but there's a decreased need, because some people don't sleep much and still tired the next day. But a person who may be experiencing hypomania or mania will not sleep much and still feel like energized and like ready to go the next day. So that's a kind of difference there.
And what challenges have you come across in distinguishing these different behaviors?
Yeah, I would say sometimes what can be challenging with these behaviors is that maybe if a person, let's say, lives alone or
Mhm.
doesn't have close social contacts, for example, then they themselves might not notice the change. And if they don't have any close social contacts, so if we think about now in life, a lot of us are working, I was going to say telehealth, but tele something. It might not be telehealth, but tele in some way. And so there, we might not have a lot of time where we're around persons. And so they don't notice a difference in that. And then also with mania and hypomania, because I, stated a person's feeling unusually happy, still happy. So that feels good. That might feel good. It might feel good to have a lot of energy. It might feel good to be like overly productive and starting a lot of business. That feels good to a person. So that's typically not the time when a person would seek, psychiatric help or mental health assistance, because they're feeling good. They're feeling, they're in a good mood. They got good energy. They're creating new, like maybe organizations or something like that. So that can be hard, because that's the person usually comes in when they're depressed. And when they think about those other times, even if I give them some examples of it, they're like, oh no, I was fine then. I was good. I wasn't I wasn't even manic. I was just, they feel good about it. So they don't even bring up, sometimes they won't bring up those other experiences.
So where do you take the conversation with when you hear that?
So what I try to do then, especially if they're just speaking to their mood and that,
Mhm.
things that felt okay with their mood, I start to look at or ask them about more of that sleep period,
Mm.
that sleep option, because that really can be different. And that's usually not the only symptom, but when a person, like I said, is not sleeping a lot and they're still very energetic, that's when I say,
Mm.
that's when something may lean more towards, this might be hypomania or mania, because if we're all human, so if we're not sleeping typically, we're going to feel tired the next day. And so if a person is describing that feeling or describing those experiences during like whatever their good, quote unquote, good times are, then I'll kind of say, let's dig deeper a little bit here, because that sleep is just like a telltale sign. It could be.
Mm.
Hmm.
Okay, this is a perfect time. Let's get into some of those misconceptions, because you kind of talked about, oh, I was fine then. And so we know one of the misconceptions people have is like, just being happy or sad. Would you like to get into how you kind of clarify the bipolar disorder from just like emotions?
Right. Yeah. Yeah. So you brought it up actually earlier when you said, sometimes people are using the word bipolar in very, casual conversation. I like how you said that. Very casual conversation. And so I've seen that. I do see that a lot in casual conversation. And so what I try to do, even when a person comes to me and says, my family member is bipolar, or, oh, my mom said I'm bipolar, I'll ask about, you know, can you tell me what, well, one, why you feel that you are bipolar, if you're telling me that, or why your family member said that about you? Did they say what they noticed? And then if they say, well, it's because they said I had mood swings. Okay, could be, could be. So then I always ask, tell me a little bit about when you have a mood swing, what it looks like. And I want them to describe it instead of me giving them like, does it look like this? But I want them to describe it. And then I also will ask them, like, how long is it lasting? Because I think that's important too. And it's different from emotions, where a person might have let's say, a negative experience happen in their life, or a stressor happen in their life, and they feel sad or down about something, but it's more transient, I mean, it doesn't last very, very long, or it doesn't strongly affect their functioning of their life. Because when we talk about really all mental health conditions, but bipolar disorder as well, it does have to disrupt the way in which a person functions. Because I talked about earlier about, it's not just a person's doing a lot of like opening a lot of businesses, because some people, that's their normal MO all the time. And that's okay, I'm not mad at it. But if you're doing something different, if this is not your, how you are normatively, and now you're opening all these businesses, that's a sign that this is something a little bit different, because now you're functioning outside what how you normally would.
And so one reason I'm really honored that you would lend your time and talent to talk about this is because of the Black community and the misconceptions that we have when it comes to mental health in general. But specifically, we want to talk about bipolar today and those barriers to care, because so often we see that historically we didn't have access to this kind of care. So we develop certain perceptions about what it is, and that continues to plague our community to the point that we're not getting the help that we need, and we don't really understand the disease that you just explained, and so we often think it's a choice, and that people are acting that way on purpose. They're doing it to seek attention. Their mother was like that. They're doing the same thing their mother did. And so if we could kind of talk about the barriers to care and what you see when you're treating Black and Brown communities where that gap in knowledge is so prevalent.
Hi, I'm Alicia from the Mel Initiative podcast. Our mission is twofold. One, to simplify complex health information so you feel empowered to ask questions, educated on how to manage your health, and confident to navigate the healthcare system. And two, to elevate the expertise of nurses, spotlight the diverse career opportunities within the healthcare industry, and inform our peers how to leverage their expertise as clinicians and entrepreneurs. In less than 2 years, we've grown to over 50,000 views and 1,000 downloads, with an international audience spanning the US, Canada, the UK, Australia, and more. Our engaged listeners are professionals, entrepreneurs aged 25 to 44 who value authentic, impactful content. Want to connect with this dynamic audience? Advertise with us. Send in your 1-minute video ad and let's amplify your brand. Email tmi.melanin@gmail.com for rates and details. Let's work together.
Yeah, I would say that, when I do work with, and I often do work with Black and Brown patients here in Virginia, that I will see, yes, that misconception about bipolar disorder, and also a misconception and worry, which is valid, about medication or the treatment options, I should say, or the treatment options about it. There is a worry about like side effects of medication and what that will do, in the long term. There also is, that's something that other people have, persons in the more dominant culture might have, but not us. And so I think there's that thought, what you just mentioned about, is that like a kind of a choice, type of thing. Or they may, they're right, they may believe that it is also, something that, well, my family never had this, and so how do I? And in actuality, and sometimes I do this education where I say, well, it's possible that your parent or person, family member maybe did, but again, if there wasn't that access to care or understanding, this may have led to why, for some persons, may have entered the jail system or legal system in some ways. This is why, the person, had these kind of experiences in their life, because I do know what can happen is that with Black and Brown persons, when behaviors come up that are not the normative, that there is a thought that, oh, this person must be dangerous or something such as that. And so instead of getting mental health care, the person got punitive care in some way, or not even care, punitive actions, I should say, in some way. So they never, if you've never seen care given to someone in your family, then you think like, well, I can't possibly have that because nobody ever, got that kind of care. So it must not be in my family, type of thing.
Yeah, and it might lead to polysubstance abuse, so smoking, drinking,
Mhm.
drugs, not keeping a job, not staying in school, not
Right.
having stability,
Right.
right?
Yeah. In different ways.
And
Right.
even
Yeah.
distancing themselves where we just never see them again, right?
Right, right, right. Oh, he's just off on his own, or she's just off on their own. Right. Yeah. But again, we just don't know, right, what is happening. And I really thank you so much for bringing that up as well about substance use and how there is substance use that is can be used, I shouldn't say typically, but can be used sometimes to mask or cover up or treat, quote unquote, the symptoms that they're experiencing. So then, if that's all we see is a person's substance use, or all we might know in our family history, then we're like, well, no, they didn't have bipolar. They had, alcoholism, or they had, this kind of addiction or this kind of addiction where maybe it actually was bipolar disorder and they were using the substance to either mask it or treat, self medicate or treat in some way.
And then we know one of the biggest barriers in the community is the church, right? Because
Mm-hmm.
if I have a really strong faith
Mm-hmm.
and I can pray away these conditions and I don't need medication. Do you ever encounter that, and how do you address that?
Yeah, I have encountered it a few times in my professional life where persons have a very strong faith and maybe even have reached out to leaders of their faith or persons that they trust within their faith, and maybe have been told about praying something away or doing certain traditions to help with how they are feeling, and so then they feel very guilty. Even if they made the decision to come see me, they still feel there's a lot of guilt there. And I think it comes from a lack of education for some persons who might be in the church, that they don't understand that there are these types of conditions that come up. And these are these types of conditions that come up that can lead to drug use, that can lead to different kinds of crimes being committed because of the symptomatology associated with the condition. And so, what I try to do is try to educate the person about, what bipolar disorder is. I even try to show we have a manual that we use to diagnose conditions. I even go through that with them because sometimes it can be helpful to see something in print that's not virtually on print, but it's like in a book. It can sometimes be very helpful to have that. So showing, that this is what happens. This is, look, it's under this diagnosis, and wanting to share that, and also sharing about the fact that persons on medication that I've worked with since I've worked for over a decade in this field, that they have been able to thrive. They've been able to work, able to not have these experiences come up for them by whatever the treatment option may be for the person.
Are there any particular risk factors?
For bipolar disorder,
Mhm.
yeah, I mean, I would say a major risk factor is a family member, especially an immediate family member with bipolar disorder. That is typically the biggest one. But again, that can be hard because of the reasons we talked about. If people in their family didn't get treated before, but maybe had substance use or maybe had some legal issues, then we may just attribute those symptoms to, like, oh, that person had, some legal issues or substance abuse, and not attribute it to actually maybe they were having bipolar disorder or something such as that. So that's one of the kind of biggest risk factors for this condition, is that if there's a strong, what they call a strong family history, just meaning immediate family members.
And is there something going on, like chemically or mentally, that's making these things happen?
So there is a theory about bipolar disorder, as with other mental health conditions, that there are changes in the chemicals of the brain that causes some of these kind of distinct episodes to occur and come up for a person. And so even providing some education in that way can sometimes be helpful if a person feels that it's a moral fault of theirs because they are feeling very impulsive or opening all these businesses and then they fail because they're going through a cycle of these types of episodes. And so there are chemicals in the brain that are decreased or even elevated in some ways that cause these kinds of episodes and symptoms to happen.
Anything in the literature about nutrition or epigenetics, things in the environment that might be triggering the genetics or DNA?
That might trigger the genetics or DNA. There's not a lot, at least that I know of, about those effects in particular. I think there are some thoughts about it, but not heavily kind of evidence-based quite yet. I think it's still something that they are looking into the research about.
And if you're watching or listening and you're aware you're working on that, please share
Yes.
with us. We'd love to hear further. What kind of tips or suggestions do you have for family members so that they can offer support without being judgmental?
Yes, that is a really great question. I think, what can be very helpful if they notice a family member or think just based on knowing their family member very well that that person may be experiencing bipolar disorder. I think one thing to, be able to speak to that person and mention that you have noticed changes. Just start like there. Like I have noticed changes, and just see if the person is able to reflect back that they have noticed those changes too or felt differently in any way. Sometimes a person will say, yeah, I have felt really down. I just don't want to get out of bed. I just can't even think straight. Sometimes they will actually mention that. Sometimes they may not, but that may happen. And so I think that can be helpful to open up the conversation if you just start with what you've noticed instead of starting like, oh, I read this or I heard this podcast and I think you have. Yeah, that's gonna come off a little rough. But if you start off with what you've noticed and see if the person's open to that, I think that can be a start. And then if the person is like more open to it, you could even ask, have you felt this way before? Has this happened, to you before where you felt like this, whatever things that you've noticed, you can ask them about that. And if they have, then you can start maybe saying, okay, I was wondering, do you think this is related to, having depression? Do you feel like it's heavy like depression? And even sharing some literature or a website with them. I like to use NAMI, which is the National Alliance of Mental Illness. It's very people everyday reader friendly information on there. And so it could be helpful to share this with the person again, if they're open to it and they can really, like I said, it puts it in layman's terms, puts it in very easy to read terms. And if they're feeling like that is aligned with how they feel, then they might, be open to seeking treatment or speaking to someone further about what's going on.
And so in that visit, in terms of what people can expect, they're going to come in. You mentioned screening. So you have a tool that you use.
So one screening tool that we'll use often is called the Mood Disorder Questionnaire. And so that is a tool that asks about maybe 6 to 8 questions. And it's just kind of a yes or no, asking to have these symptoms occurred in a period of time. And the person can fill that out. They can fill it out with their family member if like they don't remember, but need the family member to kind of reflect back to them those experiences. And that questionnaire probably takes easily 2 minutes, 2-3 minutes. It's not, and that doesn't take very long at all. And so you may have that screening tool first, and then the person that you're having the meeting with, whether it be, like I said, a psychiatric nurse practitioner, psychiatrist, or a physician assistant, then what will happen is that the person will take a look at that screening tool. And if you did document or say there were a lot of yeses, so to speak, then the person is going to ask you more about those experiences, about how frequently have they occurred, how much they've affected like your work life or family life or any parts of your life. They're going to ask you about, like I said, episodes happened before, how long have they happened? But then they're also going to make sure to ask you questions about other areas of your life as well. And I want to let people know the reason that we do ask about all areas of life, such as school and medical history and things like that, is that sometimes, in some cases, a person may have symptoms that are similar to a mental health condition, but they might actually be related to a medical condition. They might actually be related to a stressor in your life. They could be related to, if a person is using substances, it could just be related to a substance use disorder. So even though we want to know about the symptoms that brought you in, we also want to know about these other areas to make sure we're just treating you comprehensively and thoroughly assessing all the aspects of your life.
Really good point. And you mentioned a very popular book. You didn't say what it's called, but can we introduce that to the audience and tell them how it's utilized?
The DSM?
Yeah.
That one?
I don't know what edition y'all.
Now I gotta look at this one. So yeah. So So we're on the DSM-5 TR, and this is a diagnostic criteria manual that psychiatric providers, including therapists, utilize to help us to diagnose conditions in the mental health field. And so this kind of information, one, can also be found on the internet if you're looking for criteria for any mental health diagnosis. But it's something that we studied in school a whole lot. So I know a lot of it by heart, but there's still some I don't. Yeah. It's probably 900 pages. And so, but sometimes there are things that, because it is 900 pages, some things I don't quite remember or need a refresher on. And so we may utilize this book even in the appointment with you as we are listening to the symptoms you've been experiencing, that we're hearing maybe feedback from family about what they've noticed about you. But it is a book that's used for the criteria of mental health conditions.
And so now you've established a diagnosis, you're ready to make your recommendations. Medications might be one of those recommendations, right? And so what kind of medications are you recommending, and how do they work?
Yeah. So typically for bipolar disorder, there are two classes of medications that we will recommend, prescribe, or even discuss with you as far because it's always going to be your choice. And so I always like to share with patients that I will discuss something with you first, and then you let me know kind of where the next steps are, because it's a collaborative experience. So I try to make it as best as possible. So the two classes of medications are, one class is called mood stabilizers, and it kind of tells you what it does in the name, right? That it helps to stabilize the mood by preventing manic or hypomanic episodes, but also by preventing depressive episodes. And it works by really helping to manage the chemicals in the brain that we think are related to why bipolar disorder happens. So creating a balance in the brain. And sometimes I'll use the analogy is, if you think about like a multivitamin that you might be recommended to take. You take it every day because your doctor, physician assistant, your nurse practitioner is saying that, you know what, your levels of, let's say your vitamin B is low. So you need to take this in order to get that balance restored of that vitamin B. Same thing when it comes to, I won't say same, but similar thing, I should say, when it comes to a mood stabilizer. It's helping to balance out something where there might be a deficiency. And so I tell people to think about it in that way, if that helps, because that's something that maybe people have known to take a multivitamin before, or some type of vitamin C even. And then the second class that we might recommend, or at least we might talk about with you, are medications that are called second generation antipsychotics. And that is the class of medications. And I do know when people hear that name, antipsychotic, they do have some worry and concern about that and what that means. And I always try to share that is the name of the class. And I want to tell you that because I know you're going to Google it. So I'd rather tell you up front that you might see that than you find it and we haven't talked about it. So what I tell people about that class is that they were originally, most of the medications in the class were originally created to treat psychosis, to treat schizophrenia. That's why they were originally created. What we found as we continue to utilize them is that they helped with other symptoms too. They helped with other brain imbalances as well. So we're not giving you the medication because you have any psychosis or we are saying that you're psychotic. It's just kind of the class of the medications that we have and can help with so many different things. And so I just like to express that because, again, I know that name can be a little, we'll say, alarming.
Yeah, you did a beautiful job explaining that. And it's really a great tip, not only for the public, but for our peers on getting ahead, right? So we can continue that trust and rapport we have with our patients, so that when we do have to make scary diagnosis and offer medications that they're unfamiliar with, that trust will be there. And they know that we'll be there with them through that process. So if someone does get prescribed a medication specifically for bipolar, will that be something they'll be on forever?
That's a very good question. So typically, I would say with the research that we have and the body of research that we have, and even the long-term studies, the recommendation is for the person to be on that medication for for what we call maintenance. So like being on a multivitamin for a long period of time, being on this medication for the rest of your life, because it's going to help to prevent those other types of episodes that might disrupt your life in ways. And we definitely don't want that. We know that a lot of our patients have different goals for their life, whether that's work, family, things such as that. So we want to make sure that they reach those goals. And we know that that disruption can prevent them from getting to their goals. So usually it's recommended that it's something that is lifelong. There are, I would say, a few persons who I have seen be able to come off medications and do well. But I would say that is a little bit more infrequent that I've seen that, but it is a possibility. So I want to let that be known. But I would say for most cases, it will be lifelong.
And that maintenance, are you talking about like just like a smaller dose than maybe you start them on?
It's possible. Yeah, definitely possible. When I used to work with a certain collaborating physician, he was very, very smart, very, very just knowledgeable. He always stated to myself, and then also working with the patients, that, the medication, or the dose, I should say, that keeps you well does not always have to be the dose, that gets you well, doesn't always have to be the dose that keeps you well. Sometimes there's an ability, especially if a person is doing well for a sustained period of time, let's say 1 or 2 years, where we say, let's try to get you to the, minimum effective medication usage. And perhaps that's 5 milligrams less, perhaps that's 10, perhaps that's 20 milligrams less. But if a person is open to doing that, it's always, I always recommend you have that conversation with your provider about that, so that you guys can make that plan together. Because during that time of decreasing the dose of medication, that is typically when I'm going to ask the patient, let's have more frequent appointments with each other so we can just monitor it together.
Yeah, wonderful. So you might recommend medication. You might recommend psychotherapy. Is that correct?
Yeah, psychotherapy as well can be very helpful for bipolar disorder. And I would say, it's been especially found to be helpful for the depressive episodes, and also for really understanding and coming to an awareness with the diagnosis as well. And you might say the word acceptance of the diagnosis as well, because I know that can be hard for persons, and people may feel like, oh, now I have this mental health condition, it won't allow me to reach my goals. And so working with a therapist can be helpful in helping with shifting that mindset, helping you to realize the things that you're still able to do and can do, even though there's a diagnosis that you have, mental health diagnosis that you have.
And by psychotherapy, are we talking about like talk therapy?
Yes, talk therapy. So this is usually done. There might be different names that you might see when it comes to talk therapy. Sometimes it's under the label of psychologists. Sometimes you might see a label that says LCSW, so licensed clinical social worker. That person is also a therapist. And then you may see something that says LPC, licensed professional counselor. That person's also a therapist. So you might see a lot of different acronyms. And so I wanted to express that too, because sometimes it can be confusing. I will admit, of like, oh wait, is this the right person? Is this not the right person? There may just be different acronyms, but that they are doing talk therapy. And I would typically say, from the therapists that I work with, they will usually see patients every 1 to 2 weeks. And sometimes if the patient is doing well, they start to elongate it out to maybe once a month, every 2 months, or just as needed. It just kind of depends on what you both decide together.
And since you mentioned, you've done a beautiful job explaining the different people they might encounter on their team. I think you've covered everyone, and including social workers, right? What role do they play in this?
Yeah, so for some persons, there may be the social worker, right, might be their therapist, but in some cases, they might have a social worker who is what we call a case manager. So this is a person who will work with you on connecting with resources that might be needed. This is someone who also will help and can help with making, we call it like I'm not going to remember the acronym, but an overall wellness plan for you. So they are someone who will check in with you, will make sure that you have, your primary care appointments. Are you connected with a therapist? Are you connected with the psychiatric provider? Are you in need of any types of resources to continue to support your functioning? And if that is the case, they can be someone to help be the connector, so to speak, of those resources, depending on, kind of where you are in your journey. Because for some people, there are episodes that happen that can really disrupt a person's functioning for a period of time. And so they might need more of that, case management support to help them out during that time as they continue on their journey to wellness.
And what about primary care? They're a big friend of ours here at the show.
Yeah.
You keep them looped in?
I do. And I recommend any of my patients who do not have a primary care provider to get one because I think that is very helpful in having primary care provider because as I was stating earlier, the reason when we do that psychiatric interview, we get into all your business of all, into all your business is because there can be medical things that do come up as you continue to just live life, nothing of your fault or anything like that. And so making sure that you have that continued primary care connection, even if it's not someone you need to see every 3 months or something, but that you're checking in with, once a year and things like that, that's going to be really important because lab values can be very important. Sometimes some of the medications can change lab values as well. So, having that monitoring, just the overall monitoring going on can be helpful, as well as, like I said, if any other medical thing comes up, we can say, okay, you just had your labs done. So these symptoms of depression may be likely not related to anything, medical.
Anything else about treatment that you typically recommend outside of the psychotherapy, medications, following up with primary?
Yeah, I like to recommend support groups. That's just a me thing. I really do. I think it can be really helpful when someone has a diagnosis that let's say maybe they heard about it, maybe they heard of the diagnosis, and from what they hear, because all we hear is the worst things in the media or different places, we can hear the worst things, and so when they hear that they have that, they might be very devastated and not know anyone else who has that condition. And so I think it can be very powerful to be in support and fellowship, so to speak, with other persons who have that diagnosis, who can show you, how they've been able to, how their journey has gone, and to see the variety of, ways persons, are able to function through this diagnosis. And so there are 2 places where people can get that kind of support. One is NAMI, that's the National Alliance on Mental Illness. They have a chapter for each state and then have like sub-chapters for each like area of the state. And so they'll have online as well as in-person support groups, and they'll have resources there. And if you connect to that support group and you're looking for some type of resource, there's probably someone in the support group who knows. And then the other website and organization is called Mental Health of America. Again, they have chapters in each state and might even have sub-chapters as well in different regions of the state. And again, they have support groups as well. They will often have what's called a peer support line too, where you can, if you're just feeling like overwhelmed by the diagnosis, overwhelmed by what's been going on, you can call someone who has lived experience with a mental health condition and just be able to talk. It's not a crisis line, it's not a suicide line, anything like that, but it's just a peer line for talking, just for talking to someone who has lived experience of having a mental health condition, which again can be very supportive as you kind of navigate this new condition and new diagnosis.
Yeah, I'm so glad you brought that up because it just shows people how comprehensive the care should be, right? All the different ways you can get that support, especially for those people who still might be apprehensive about medication, right? We know that that's a real thing.
Yeah.
At least they know that there are a lot of options available. And while we do see more people talking and being more transparent about their diagnoses, we know that there's still a large percentage of the population that still has that shame, and they're not talking about it. And it can be very isolating, very lonely, especially if, no matter what position, but particularly find our leaders, our peers who are in these high power positions, it can be very embarrassing and, scary to announce. People start to doubt your confidence, doubt your positioning and your leadership and your judgment. And so it's so good to have these support groups and to see people just like you and how they're managing life.
Yeah. Oh, thank you. Thank you.
What about at the end? We like to do 3 TMI takeaways for the audience. For the audience, if they don't remember anything else you said, what do
you want to remember? Okay, so remembering that when it comes to bipolar disorder, that it is sustained mood changes, sustained mood episodes. I think that like underline the word sustained so that it's sustained mood changes. And when that's happening, there's a likelihood that that could be a bipolar disorder when they'll have those sustained mood changes of depression and very elevated mood states if they're having both of those. Also, we want to make sure that when we are having a conversation with someone who we care about, whether it's a family member or friend, and we are very worried that maybe they have this condition or any mental health condition, that we start out with what you, the person, are noticing. I think that can be very opening up of the conversation if you do want to support someone who you feel does have a mental health condition or does have bipolar disorder. And lastly, I really think it's so important. We already just talked about, but support groups. I do think support groups are important. I do think having people who you can connect with who also have the mental health condition that you've been diagnosed with can be more helpful. And it's even more helpful than working with me, to be honest, because they know someone who's taking this medication or medications like it, who's going to give them the real deal, happy meal about, the medication, about their experiences, more than myself, because I haven't taken the medications. And so it can be so much more impactful than any of the research I can share with you, any of the like data I can share with you, having someone who's been through that journey be able to really give you that real talk.
That's so true. And are you accepting new patients?
At this time, I am taking a pause from new patients, but we're in 2024. In 2025, I will definitely be likely open to taking a couple new patients.
And how can people connect with you?
Yeah, if you want to connect with me, the best way to connect with me is through my website, the pmhnpsource.com. Through there is a contact us. And if you are looking for mental health services specifically, just type that in the contact us and I will connect with you and see what I can do to help. And even if I cannot, for various different reasons, maybe insurance, or if that's the case, I still ask people to contact me because I know a lot of colleagues in Virginia who are taking new patients or take a lot of different insurances that I may not take. So still reach out. Even if you're like, I'm not sure, reach out. I'll get you connected with somebody else. I don't mind. I don't mind.
Speaking of reaching out, you also offer mentorship services. Would you like to tell the audience about that?
Yeah, so I offer mentorship services for new psychiatric mental health nurse practitioners who are just getting started in their career and might be feeling a little bit lost, might be feeling very worried. So I offer professional development and educational resources as well to just ease that kind of transition to practice period. Because as you may know as well, that from, school to the real world can be a real serious jump. And having that support of people who've been through the journey as well can be so helpful and impactful. And so if you're interested in any of those services, you can also find them on the pmhnpsource.com.
And we'll definitely have all those links in the description box. And lastly, you're the founder of an exciting new society. Would you like to give them a plug and tell people how they can learn more?
Yeah, so I am a co-founder of the Society of Psychiatric Mental Health Nurses Mental Health Nurse Practitioners of Color, and this is a new nonprofit organization that I work on founding with two incredible PMHNPs who I met through LinkedIn. I met them through LinkedIn, actually. And we are starting this nonprofit because we want to help support PMHNPs of color have a supportive place to learn and grow, as well as making sure we are providing education to the healthcare field in general about inclusivity in care, culturally inclusive and safe and competent care, because that is so, so very important. Though I am Black and I can provide care to Black patients that is culturally competent and culturally even aligned, I know that I cannot see every single Black patient in my city, in my state, in any of those things. And so I want to make sure that we're also putting out that education to let people know that, we're all a part of this journey. We're all a part of creating this space where patients feel seen and heard and understood.
Beautiful. Do you want to shout out those co-founders? Our audience is familiar with at least one of them.
One of them, yeah. So yes, one of my co-founders had a recent episode, Anyi Atavong, Dr. Anyi, and then shout out also to Letizia Baxter-Smith as well. You got to have her on in a future episode as well. I know she has some really great insights to share.
Yeah, the invitation is wide open. All of you all are welcome back. Maybe we even have a board episode with the board and learn more. And yeah, we have to thank Kirby for her time and talent today, not only informing us about bipolar, but also agreeing to come back and talk to us about vicarious trauma in providers, a really important topic. Anything else you want to leave off before I sign out?
No, that is all. This was such a great conversation and just so helpful for me to even think about, okay, what else can I give them? What else can I give them to help support it?
Yeah, you did a fabulous job. Thank you so much. Remember, everyone, you can email us your questions and show ideas to tmi.melanin@gmail.com. If you haven't already, this is your chance to subscribe to our YouTube channel or whatever platform you're watching. Leave us a comment and rate us on the Apple and Spotify podcast. It really helps you support us so that we can get this information to those who really need to hear it. All the resources that we mentioned today are in the description box, as well as how to connect with our special guest here. Please follow her and us at all of our social media platforms. At the time of this filming, we release new episodes, new videos weekly on Sundays at noon Eastern on YouTube, LinkedIn, Facebook, and Instagram. And we drop the audio at 5 a.m. on all your favorite podcast apps. So our night shift friends can be the first to get something and not the last. And maybe someone will play it during huddle and tell us about it. We thank you all for watching. We'll see you next time.